Hello, everybody. My name is Noah Brown. I'm a physical therapy student, and today I'm going to be talking a little bit about what we do for helping with bronchopulmonary hygiene, things like postural drainage, as well as chest PT. Bronchopulmonary hygiene is an important component of the treatment for a lot of patients that you'll be seeing, especially in the inpatient setting. Conditions like cystic fibrosis, as well as COPD, and many other pulmonary complications can result in the need for bronchopulmonary hygiene. And it's intended to prevent atelectasis, which is the collapse of the lung, by aiding in ridding the patient of secretions, which ultimately can lead to respiratory infections. And normal airway clearance is dependent upon the mucociliary clearance system, which is pictured on the right, as well as the ability to have a productive cough that has adequate force. So the mucociliary system is the system that uses the cilia, or the little hairs, to push the foreign particles up further towards the larger airways so that they can be coughed out. So before we dive into this, it's important to go over a little bit of relevant anatomy about the lungs so that you can identify where certain lobes are, and it also helps with making the positions for postural drainage really make sense. So the right lung has 3 lobes and the left lung has 2 lobes. So the right lung is a little bit larger. There's the upper lobe, the middle lobe, and the lower lobe. The upper lobe is further divided into the apical segment and the anterior and posterior segments. And on the left lung, you can see here that there is a portion of the upper lobe that is called the lingula. And for our purposes, and especially for postural drainage, the lingula is effectively considered the middle lobe of the left lung. It's also important to have a pretty solid understanding of the layout of the bronchial tree. So, pictured here, you have the lower respiratory system, which has both a conducting zone as well as a respiratory zone. Conducting zone being the trachea and the primary bronchi and bronchioles, and the respiratory zone being the respiratory bronchioles, alveolar ducts, and finally the alveolar sacs, where the gas exchange will actually be occurring. Physical therapists, respiratory therapists, as well as nurses all utilize postural drainage positions, which are designed to position certain lobes of the lungs into a gravity dependent position so that gravity will aid in the mobilization of those secretions, and along with chest PT and other breathing techniques, hopefully bring the secretions from the peripheral aspects in the lungs more towards the central airway where they can actually be coughed out. Before we talk too much about the positioning for the different lobes, it's important to go over just some important terminology that'll be used throughout. So, Trendelenburg position refers to a 15 to 30-degree head down position. So, it's typically used for the middle or lower lobes. Basically, you are trying to put them in a position where it aligns with those terminal bronchioles to allow for greater clearance. And the reverse Trendelenburg position is the opposite. So it's 15 to 30-degree head up position. And traditionally in the literature, you see the 18 to 20 degree of elevation being used for either Trendelenburg positioning, being 18 to 20 degrees head down, or reverse Trendelenburg being 18 to 20 degrees head up. And also pictured here is what's referred to as Fowler's position, which we'll get into later, is used for the apical segments of the upper lobes. To drain the apical portions of the upper lobes, you position the patient in long sitting with a pillow under their knees with the head of bed elevated around 60 degrees, and this is what is referred to as Fowler's position. For the left upper lobe anterior segment, you're going to have them in reverse Trendelenburg, so the head of bed would be elevated about 18 to 20 degrees. For the right, you're going to have them with the table flat, and again, pillow under the knees for both of these people. For the left upper lobe posterior segment, you have two options. The first of which is effectively the same as the anterior segment, but instead of them laying on their back or supine, they are more prone and or a little bit on their side, so quarter turn with pillows underneath their legs. You can also position the patient sitting and have them draped over a table with a pillow underneath them, and that can be really helpful to get at the upper or the posterior segment of the upper lobes. The posterior segment of the right upper lobe is drained in a position similar to that of the anterior portion of the right upper lobe. The table has no incline, and the patient lays in prone with that side facing up, so slight quarter turn upwards. The left upper lobe lingula and the right middle lobe, like I said before, for our purposes, the lingula can effectively be considered the middle lobe for the left lung because the left lung only has two lobes. So you would position them both in Trendelenburg position, so 18 to 20 degrees head down, pillow between the legs, and they are in side lying. For the superior segments of both lower lobes, the patient is prone with pillows under their ankles and a pillow under their head for comfort, but the table is flat. So no incline for the lower lobe superior segments, as well as the right upper lobe posterior and anterior segments. Now for the lower lobes. So if you wanted to drain the anterior segments of both lower lobes, you would have them in Trendelenburg, so head down position, and they would just be laying flat on their back with a pillow under their knees and their hips in slight external rotation. For the right lower lobe lateral segment, they are again in Trendelenburg position because we're working with the lower lobes here, and they are going to be in side lying. Again, pillows between the legs for comfort and a pillow under the head. If you wanted to drain the posterior segments of both lower lobes, they would be prone with a pillow under their stomach, and they would be in Trendelenburg position. The lateral segment of the left lower lobe would be drained in the opposite position of the right lower lobe. So they're in Trendelenburg, side lying, but they're laying with that left side up, as opposed to if you're draining the right side is up. So a lot of this stuff really makes sense and is pretty more or less obvious should you know your anatomy pretty well. Along with postural drainage, physical therapists can apply manual techniques which can assist with clearance as well as breathing function in our patients. So this is also referred to as chest PT, and it consists of percussion, vibration, and shaking. Percussion being performed during inspiration and expiration, whereas vibration and shaking are performed exclusively during expiration. And during these manual techniques, the patient should be encouraged to cough to mobilize the secretions throughout the duration because ultimately you can mobilize the secretions all you want, but if the patient isn't able to cough them up and expel them, then all your work is for nothing. When performing chest PT on a patient, percussion is the first and most often the most well tolerated technique to mobilize secretions. So it involves rhythmic chest clapping over the involved lung segments by alternating wrist flexion extension using a cupped hand, which you can see in the picture. So when you're doing this, it should be a nice steady rhythm and it should be relatively forceful, but you should gauge your force based on the patient's sign and symptoms and whether or not they're tolerating the treatment, etc. So you're looking for a nice hollow sound because we're intending to impart the force onto the patient's thorax via the air that's trapped between your hand and their thorax. So it's much easier to tolerate higher forces when you cup your hand because then the force is distributed across the whole surface area because it's coming from the pressure of the air. And percussion is performed during inspiration as well as expiration while they are positioned in the position that will drain that specific lobe. And it is performed for 3 to 5 minutes for each individual segment. And you always want to perform percussion and every chest PT maneuver over clothing or drape the patient with a sheet because you don't want to be causing any abrasions or causing too much discomfort to your patient. Chest PT can be performed on infants and is often indicated. However, they may require modified positioning. For example, most infants do not tolerate the Trendelenburg position or the head down position, um, especially if they are born before 28 weeks gestation. And you can apply percussion to the infants, but it's got to be much gentler, of course, than you would on someone who's a full-grown adult. And you don't use your whole hand. Instead, you would use 3 or 4 cupped or tented fingers to very lightly percuss the infants. You can also use those little rubber nipples, the pediatric face masks, or the bell of your stethoscope, as long as it's not too hard and it's not going to be something that the infant wouldn't be able to tolerate. You can do gentle vibration on the infants, but shaking is contraindicated, and I'll go into those two techniques in more detail in a bit, but it's fairly obvious why shaking is contraindicated on the infants. So after you're finished with your 3 to 5 minutes of percussion, you can now do vibration. So alternatively, vibration is performed with a flat hand, unlike percussion, which again uses the cupped hand. And this is an important distinction to make. So when performing vibration, we're trying to impart a gentle but high frequency oscillatory force to the desired lung segment. And we do this by keeping our arms straight and locking our shoulders and basically initiating co-contraction in our arms to create that vibratory motion in our hands. And these techniques are performed only during expiration, so the patient will breathe in, and then as they breathe out, you will apply the oscillatory force, and they do so for 3 breath cycles, and then you move on to the last technique, which is shaking. Shaking is the last technique in chest PT. It's also referred to as rib springing, and it's similar to vibration, but uses much more compressive force and it is performed with bent elbows to allow for the ribs to spring back into your hands, as opposed to vibration, which necessitates the locking of your arms to utilize co-contraction. So, what you do is you have them inhale and then you apply strong compressive forces that gradually increase during expiration. And this could also be used as a quick stretch to the thorax, which is very effective for a lot of people who don't have a lot of control over their respiratory musculatures, especially individuals who have a high spinal cord injury. So, what that does is it effectively stimulates hyperinflation of the thorax and can help prevent atelectasis as well as re-expansion of that desired lung. So shaking is also performed for 3 breath cycles and only on expiration. So some considerations for treatment. These airway clearance techniques should be performed before or at least 30 minutes after the patient has eaten or if they've been fed through a feeding tube. And this is to reduce the risk of aspiration during the treatment. And signs of treatment intolerance would be whether the patient has increased shortness of breath, anxiety, nausea, dizziness, hypertension, or bronchospasm, in which case you would DC the treatment and evaluate the patient and make sure that they're not experiencing any sort of medical emergency, etc. Vibration has been known to be slightly less tolerated than percussion. So, again, use your clinical judgment. Any signs of treatment intolerance, and you shouldn't continue the treatment. You can modify the postural drainage positions, but they should be as close to the intended position as is safe. Here are the relative and absolute contraindications to postural drainage accompanied with or not accompanied with chest PT. So, two absolute contraindications are acute hemorrhage with hemodynamic instability. So, that's a medical emergency. Obviously, you're not going to be doing chest PT and you're not going to be doing postural drainage, and an unstable head or neck injury. So, those two are absolute, not doing it, any of it. The rest are considered relative contraindications, meaning that there are definitely increased risks of complications, but postural drainage with or without chest PT should be considered on a patient to patient basis with a discussion with the MD, um, respiratory surgeon, respiratory therapist, etc., about the risks and or benefits to doing these techniques and possible modifiers to make them safer for the patient. So here are some relative contraindications based on the different postural drainage positions. So for Trendelenburg position, being the head down position, it's contraindicated for individuals with uncontrolled hypertension, uncontrolled or unprotected airways with the risk of aspiration, hemoptysis, recent esophageal surgery, a significantly distended abdomen, untreated tension pneumothorax, and acute congestive heart failure or cor pulmonale. Reverse Trendelenburg position, so head up, is contraindicated for individuals with hypotension or the use of vasoactive medications. And for prone, these are all relatively straightforward. They usually involve some sort of open incision on the anterior aspect of a patient's thorax. So you don't want to position a patient if they have an open wound or a catheter or feeding tube in their stomach or chest area. So here are some of the precautions and contraindications to chest PT, which would be percussion, vibration, and shaking. The precautions are pretty straightforward. Individuals with osteoporosis or previous rib fractures, that can be really dangerous, especially for vibration and shaking. So you want to be careful with that, and if anything, you're doing your techniques with very minimal pressure. Contraindications, you of course are not percussing, vibrating, or shaking any open wounds or skin grafts, and if somebody is hemodynamically unstable, you're not going to be doing really anything of the sort. No postural drainage techniques and no chest PT. So after we've performed chest PT in the postural drainage positions, it's time for our patients to actually clear the secretions that we've hopefully mobilized towards their central airways. So there are a number of clearance techniques. The first being just a cough, huffing, an assisted cough, where we physically assist them to compress their thorax and forcefully expire. A splinted cough, which is effective for individuals who may have sutures in place on their thorax or their abdomen. And then the trach tickle, which is largely used in individuals with either a spinal cord injury or individuals who are intubated to um, manually stimulate the cough reflex by gently tickling their trachea. Forced expiratory maneuvers include coughing and huffing, and there's a nice quote up in the top right there which says that forced expiratory maneuvers are probably the most effective part of chest physiotherapy. And I think that really makes sense given that this is how we actually cough up these secretions, and everything else is utilized to mobilize the secretions towards the central airways. So, what happens during these forced expiratory maneuvers, being either a cough or huffing, which is similar, there is a dynamic compression and collapse of the airways downstream. So, what that does is effectively pulls mucus or secretions towards the central airways. So in the picture, you can see that the force of contraction from the expiratory musculature is causing a significant increase in alveolar pressure. And then if you look up in the central airways, the pressure is zero. So these forced expiratory maneuvers push secretions towards where they can actually be expelled. So huffing can be particularly effective at mobilizing secretions for a number of reasons. The first being that the viscosity of the mucus that's in the lungs is shear dependent. So when you huff, you generate shear forces that reduce the viscosity of the mucus, which effectively allows it to travel further in a shorter amount of time. Huffing to low lung volumes helps move secretions peripherally to upper airways, and huffing from a higher lung volume can be used to clear the secretions once they've moved into the upper airways. Now, doing extremely high lung volume huffing is not necessarily recommended because it results in an unnecessary energy expenditure. What is recommended is a mid lung volume huffing with a medium-sized breath and air being squeezed out using the abdominal muscles with the mouth and the glottis open. And too short of a huff may be ineffective. Too long can result in unnecessary paroxysmal coughing. So you end up stimulating the cough reflex and you can't stop coughing, and it tends to be a unproductive cough. So here are some steps to instruct patients on how to huff. So it consists of three phases. The collecting phase, which involves slow breaths in and out at low lung volumes, followed by a 2 to 3 second breath hold. And the 2 to 3 second breath hold is really important for patients, especially if they've been um, either they were operated on or they've spent a lot of time in the hospital because it helps with re-expansion of the thorax. So after the collecting phase, you have the evacuating phase where the patient breathes at their normal tidal volume, but it's interspersed by 2 to 3 second breath holds. And then finally, you have the unsticking phase, which involves deeper inspirations from low to mid inspiratory reserve volume with breath holding followed by a huff. So I just thought I'd also include a really quick, easy step-by-step way to teach your patient how to cough effectively. So a lot of your patients may not really know how to properly cough, or they might be scared to cough, um, whether because of pain or whatever. So what you can do is you can have them first try taking deep breaths in, and then you can do or rather you can see if they can take a deep breath in and then hold it. Try and have them hold it for, again, 3 seconds, and then tell them to take a deep breath in, hold it, and then bear down, tighten their stomach and their throat, and cough, trying to really cough as loud as they can. And usually, if they're able to do the deep breath in with the hold, they can then do the cough at the end.